Let me try and screen share. Just tell me if you can see it. Can you see that?
Yes, we can see it.
Great. And you saw how many slides I have. So I will try and be as fast as I can. Okay. And you can hear me too, correct? Okay.
Yeah.
So this was the developmental behavioral PEDS evaluation. I'm Abby. I'm one of the fellows. And my supervisor is Dr. Williams Aria. So for presenting concerns, so this is for Jonathan. I can say his name, just can't type it. So he is a 4-year-old, 2-month-old boy presenting for outbursts, violent behavior towards sister, and anger issues. That was the initial referral information. In terms of mom's concerns, when we met with her, there were behavior difficulties at home and at Head Start where he went to school, aggressive behavior towards other kids, frequent tantrums, and then mom did have a concern for autism given a strong family history, which we'll get into. So developmental history-wise, he met milestones on time. He actually crawled around 8 months. He walked a few months after, which would put him right on target. He did struggle with walking and running smoothly due to out-toeing, so he did get physical therapy through early intervention. He said his first words around 1 year of age, which was appropriate, and there was no regression reported. Communication-wise, he uses complete sentences that are difficult to understand. He uses gestures appropriately. Receptively, he responds to his name. He understands the word no, whether he follows it or not is a different story. And he can follow multi-step directions, but pretty inconsistently is what mom reported. Pragmatically, he makes good eye contact. He can have back and forth conversations when he wants. And this is just a brief overview, so I'm sure speech kind of got more into it. Social skills and play-wise, so he does attempt to engage, but he did struggle with turn-taking and sharing. Mom has seen him steal toys from other kids rather than actually playing with them. He often escalates to aggressive play. He enjoys really active activities, so that includes using his scooter, running around and playing with balls. And he consistently seeks out his family to play or show, involve them in his play. In terms of his pre-academic skills, he cannot consistently label numbers, letters, shapes, or colors. And mom was not sure if this was him not knowing it or him refusing to cooperate. So there was a little bit of variability there. Tantrums, aggressive behavior. So this is really the meat and potatoes of what we got into. So tantrums and aggressive behavior occur multiple times a day. Mom estimates that they see a tantrum about every 30 minutes to an hour, which is pretty frequent. She was saying that dad is home with him and is calling her kind of all day to report issues. Timing is variable, but can last up to an hour. He will scream, throw himself on the floor, hit, and throw toys. The prompts for his tantrums include being told no, not getting his way, transitions, and not being understood. Mom reports that he is just generally not gentle, and she's had to hide his scooter to prevent him from scootering over his baby sister's hands and feet. So that's particularly an issue with the little one. In terms of discipline, so I mostly got about mom's discipline strategies. So I do kind of feel like there's still a little bit of a gap with what dad is doing. Mom will hold him tightly. She feels like actually tight pressure helps him to calm down. So some of that may be a sensory thing. She has also tried ignoring, saying no, and timeouts. Most frequently, she said she actually sends him to his room to have him calm down on his own, because that seems to be the most effective. In terms of ADHD symptoms, these were first noted in early childhood, although he is only 4. So they're present at home and school. Mom reported difficulties with inattention, hyperactivity, and impulse control. So kind of all of that. Elopement issues, he has run into the street before. He does not allow mom to hold his hand in public. Interestingly, it's not an issue at home because dad has made that boundary pretty clear. So in terms of that at home, dad has been the main enforcer of that, and he has responded to that. Mood-wise, they described him as kind of an emotionally labile child. So he's either angry or happy. He's quick to show anger. And he shows kind of high extreme amounts of anger compared to what the situation is. There were actually no concerns with anxiety. Restricted repetitive behaviors wise, they did not report any repetitive behaviors. They reported some behavioral rigidity, so he does do better with routines. Mom does feel like they see a little bit of an improvement when he's consistent with Head Start. He does struggle with big transitions. For example, they were having trouble keeping a teacher at Head Start. And so mom said they actually had to pull, I think it was the director of Head Start who had been his previous teacher, into the classroom to help him adjust. Perseveratively, the one thing she did report was scootering back and forth in the hallway of their house, which could also be a repetitive mannerism, or it could just be a sign that he's very overactive. Sensory-wise, she did report some difficulties when he was younger, but has outgrown many of those concerns. She did report that he likes like tight pressure, which is why she kind of resorts to holding him, but he likes kind of tight clothes too. So this slide is important because of mom's concerns for autism. So this really draws us to that second criteria for autism, which is not super convincing one way or the other. Motor skills, so there was a lot, although I would love to hear what my PT colleagues have to say. She reported that his right foot turns out, he actually compensates pretty well for that, but it's more so when he's tired. She has been told by a physical therapist that he has weak left ankle ligaments. So he does not like, on his right foot, he does not like to flex or point his right foot. But he will allow it to be kind of passively dorsiflexed and plantar flexed, so pointed and flexed by other people. She has reported that he's had braces for both his right and left feet/ankles, but has kind of inconsistently worn them because actually a different physical therapist told them that he didn't need them. So I think she's just confused as to what she's supposed to be doing. He last saw physical therapy over a year ago. Fine motor wise, he can pick up small items with a pincer grasp. He uses utensils to feed himself. He can hold a pencil and crayon appropriately, she reported, and he dresses himself independently. He is left-handed preference. His activities of daily living. So sleep was an issue that we knew about going into it. So she said on average about 4 nights of the week, sleep is an issue. So he'll go to sleep around 7 p.m., but he's up until about 9 p.m. And what he's doing, he's usually kind of wandering out of his room, asking for a cup for something to drink. He needs someone to be with him until he falls asleep. So mom or dad needs to be in the room, in the bed with him. He takes melatonin 8 to 10 milligrams, but mom does not feel that actually helps significantly. When I did push a little bit more on that, it does sound like instead of 2 hours to fall asleep with the melatonin, it's about an hour. So there was maybe some improvements, but still not within the normal range we would expect. Without the melatonin, he's up all night. She kind of said it was almost like a mania sort of thing where he would just be up for a long, long time and then kind of crash behaviorally. He's a very restless sleeper, and he would only sleep for about 60 to 90 minutes at a time before he's up again. Activities of daily living. Otherwise, he's a picky eater. He is toilet trained. Self-care wise, he is independent with brushing teeth, bathing, dressing, undressing, but it really depends on if he wants to do them. So all of that's pretty inconsistent. In terms of his interventions and supports, he received EI through First Steps in Kentucky. He got physical therapy for about a year. He child care preschool wise was in early Head Start since he was six weeks old. And then he's currently in Head Start through Gallatin County Schools. He has an IEP that provides speech therapy supports, and he does not do any outpatient services currently, so no therapies. When we go into his history, it's pretty similar to what I showed you previously, but he was born full term via C-section. He had breech positioning, which just means he's kind of upside down. He had a cystic hygroma prenatally, and interestingly, mom was told that he would not be normal 100%, whatever that means. So she was expecting that. He passed his hearing screen. He had a normal newborn course after being born. Past medical history wise, he has a history of otitis media and tonsillar hypertrophy. And then he also has a history of acid reflux as an infant. In terms of his surgeries, he's actually had 2 sets of tubes placed, most recently in 2019. And he also had a tonsillectomy adenoidectomy in 2019, along with the second set of tubes. In terms of his meds, he takes melatonin, 10 milligrams daily. It looks like it's a suspension. Family history-wise, so genetics will definitely give you some more information on this, but mom reported ADHD and mom and dad. Mom reported kind of non-specifically autism on her side. Dad, I guess, has said he has autism, but mom told me that paternal grandma said that he was never formally evaluated for that. And then dad has bipolar. Social history wise, he lives with mom, dad, and two sisters, a 2-year-old and a 5-month-old. And he previously lived with maternal grandparents and mom prior to moving out a year ago to live with dad. Review of systems, nothing was remarkable. Physical exam wise, so vitals wise, blood pressure, pulse look good. He is on the higher end of the growth chart, so I'll show you all of this, but if you look to, I guess you're right, that is his BMI chart. So he's off the chart, which can look bad if we don't look at his height and weight. So his height and weight are actually very high also on his charts. So BMI is above the 97th percentile. And when we look at his weight on the left, you'll see that he's above the chart for that. So over the 97th percentile, and then height, he's also above the 97th percentile. So he's just kind of a bigger kid for his age. My general observation, so it's a big long paragraph. So if you just look at the bold, he was difficult to engage during my visit. He had a kind of significant level of attachment to mom. So he often stayed behind her and kind of hid and peeked at me. He was very fidgety throughout the visit. He would kind of run over to grab something that he wanted, like a toy or a snack, and then he'd run right back to mom. So that did make me think a little bit more anxiety than maybe mom was reporting. He did use gestures such as nodding, shaking his head. He used brief eye contact, but he didn't really sustain it. And I don't know if that's just because I was a new person. He did follow joint attention. He became upset and then later refused to participate later, which mom said was actually the first time she felt that that was characteristic of his behavior in appointments. So otherwise she feels like he's been presenting pretty well, but his refusal to participate later in my exam, she said, was pretty characteristic of how he is during doctor's appointments. Physical exam wise, so the only thing that was really remarkable was he had a right PE tube in place, which I'll be honest, did surprise me because it's been a couple years. His left TM was normal without a PE tube. And then neurologically, that was the only thing. He had full range of motion in his left and right ankle. I did feel like he maybe had some laxity bilaterally. And then when he had kind of an interesting gait, it was like a limping gait that was more limping on the right side. And he had a slightly uncoordinated run when he did run, but he was also acting really silly when we were trying to get him to run. So it's not clear if that was a true representative of what he normally runs like. And when I go to my assessment, so the overall diagnoses that I gave him were ADHD, combined presentation. Combined just meaning he has inattentive and hyperactivity, impulsivity symptoms. He met the criteria for it presenting in early childhood and being in the setting of both school and home. So that's why we made that diagnosis. Otherwise, I did give him a disruptive behavior disorder diagnosis just to kind of better categorize his behavior. I did feel like it was beyond what I would expect for his developmental level and also for his ADHD. And then the last thing was sleep difficulties. So that's just, he has both difficulty staying asleep and falling asleep. So yeah, so I think that just better, it's kind of a vague overview of what his sleep difficulties are. When we get into recommendations, so I do think the melatonin is a pretty high dose for a kid his age, and it's not doing as much effect as I would expect. So I would consider actually starting him on clonidine 0.05 milligrams at bedtime to help with the sleep onset delay, so to help him fall asleep, rather than continuing the melatonin, because I really think it's beyond being therapeutic. And then when we look at his educational setting and services, I really think that's huge to be consistent. So we'll have to talk with mom about that. Obviously continuing with the services that he's getting and maybe updating them once we have our final report. And then I do think we need to be talking with the behavioral specialist that mom reported he has at Head Start to discuss kind of behavioral strategies and making sure that's consistent home and school, because it sounds like maybe there is some inconsistency there. And then the last thing, I think he needs what is called PCIT. So that's parent-child interaction therapy. It's a form of behavioral therapy that focuses on parent interactions. That will be best done. You can do that at Children's, but you can also do it in the community. For them, it would have to be in the community. because they live so far. And that would really be best done with both mom and dad because dad is really home with him the most. So that would be something to really emphasize when we talk with them. And that's all I got.
Does anybody have any questions for Abby?
I do have a quick question, Abby. We got to observe the PT evaluation today, and he was really resistant to the physical examination when she was trying to check his leg range of motion. I was just curious how he did with your physical examination.
That's when we had the meltdown. I mean, part of it was difficult to engage him really from the beginning with me. Like he really was not wanting to separate. So once I tried to get him to separate from mom, we had more of a meltdown. He really did not want me to do any of that. So mom said that he will allow people to kind of passively like dorsiflex and all implantar flex, but I felt like he really was resistant to that. Like it really triggered the behavior. So yes, I had a hard time with it too. And we had a really hard time assessing his gait. Like he was really acting silly and trying to do everything but show us what his actual gait was.
Did you feel like it was like with any touch at any time, or just when you were like kind of assessing the leg range of motion?
Any touch really. And that was mostly like, to be honest, rapport was really difficult for me to say. You'll see on the video, like I'm approaching and I have to back away, like trying not to push him too far. But yeah, any touch, anytime I approached him, which I think was partially my rapport with him was not there. So maybe if someone gets a better rapport, maybe I need them there to get a better exam.
We had the same situation. So
okay, well, that makes me feel better.
Yeah, Abby, I'll touch on it more next week. We evaluated him this morning, but it was very difficult to get measurements of his legs. And we got some done, but I don't know how accurate maybe some of them were because he was so resisting and he did not want us to do really much of anything. He didn't feel comfortable. So I'll touch more on that next week, but I agree with all of your motor observations and I can go into more depth during my presentation next week.
Yeah, I can't wait to hear it. Honestly, I was really interested to see what PT would say.
Abby, that was a great presentation.
Great.
Oh,
go ahead, Alex.
I was just curious a little bit more about sleep, and I might have missed this, and I apologize. So you said there's sleep difficulties, and you were looking at clonidine because melatonin isn't doing its job for him.
Yeah.
What do you think? Like, did you talk about his bedroom at all? Does he co-sleep? Is there siblings in the room, or kind of his general environment for sleep?
Well, he likes to sleep with other people, so that was talked about.
Okay.
And he has a sleep onset association with falling asleep while mom or dad is there, and I do think that's difficult. So sometimes what we recommend is like fading gradually, where you're trying to get rid of that association with mom, right? Because he wakes up and he's like, mom is not there. And that's what I need to fall asleep, right? So that's part of the difficulty, right? We know that kids will wake up every couple hours. Everyone does that, whether they're aware of it or not. And then they look around for that comfort object. So if that comfort object is mom, we're trying to decrease that association. So I do think he has pretty significant sleep onset association, which is part of his difficulty with falling asleep. And also when he wakes up, that's why it's so disruptive to his REM cycle. So I think helping him to fade some of that sleep onset association and helping him to be more independent, because it did sound like they put him down in his bed, but he comes out and mom and dad end up kind of bringing him to the bed or being with him a lot of the time. So I do think they need to do like a fading technique, which we can talk about more in detail, but where they kind of gradually move away and commend his ability to withstand that and kind of check in so that they know we're not asking him to completely separate from mom or dad, but we need him to be a little more independent. So there's like a fading technique. I'll put it, sleep medicine uses it sometimes, and I can put it in there because I do think that's a significant portion of his sleep hygiene issues.
No, that's perfect. And I was wondering about like if there's any recommendations for sleep as far as the environmental and behavior part, but I love it. Awesome job.
Yeah.
Alex,
I do think there was some anxiety too. Like I felt separation anxiety was present. It's just that hasn't been demonstrated across kind of, so I wasn't sure if that was just me. So I'll be curious to see what you guys think too.
I have a lot to share on that in my presentation. Abby, I was just curious, did you start talking about medication with mom? Or are you waiting for the information sharing session?
I'm gonna wait for the information sharing session to see. That was partly just a timing thing. And and see kind of how they feel. Every family's different, but they are using massive amounts of melatonin. So hopefully they'll be open to some sort of medication.
Great, thank you.
Yeah.
Abby, they mentioned that dad has bipolar disorder. Did you get a sense of whether that's well controlled or well managed?
I'm not even
Um,
sure, and I'll have to see what Courtney got. I'm not even sure that was formally diagnosed, just
Got
like
it.
the autism, or if that's reported. That's one of those diagnoses that I feel is over-reported based on like emotional ability. So I wasn't entirely sure how much of this was formally diagnosed, because mom herself was like the autism was not formally diagnosed, but he will tell you that. So yeah, maybe Courtney will have more info on that.
Yeah, I can
Thank
talk
you.
about it. I also felt like there was some kind of confusion and just different terminology that the family used that may not be medically or, accurate. So
So that might be a nice transition. Do we want to let Courtney go ahead and get started? And then if questions come up at the end, Abby or Courtney can answer them.
Sounds good. Thank you,
Okay.
guys.
Good job, Abby.
all right, can everyone see it and hear me?
Yes.
Okay. So like last time, I was just with Abby for the whole appointment, and then I took a more detailed family history rather than having a separate genetic counseling appointment. So this is, sorry, let's move you guys. This is our family history. They have quite a large family. So our patient is the 4-year-old with the circle or circled in red. And then, of course, I just wrote out a lot of the stuff that Abby just talked about for him. And then we went through his family and just tried to see if there's any kind of significant medical or behavioral or learning things that might be related and kind of guide us towards any testing. So he does have those 2 full sisters. Both of them are doing well medically. The 2-year-old does have speech therapy. Along with his maternal half-sister, who's 8. She has speech therapy as well. And mom had speech therapy growing up too. Mom reports that she has a diagnosis of ADHD, and she also had chronic otitis media or ear infections. She actually had 6 sets of PE tubes growing up. Mom has an adopted brother, so that's what this kind of dotted line means. So that's not a biological sibling. Her father and her paternal half-brother had some learning challenges. This was kind of hard to, mom just didn't have any real details. There was not really any diagnoses or particular areas that were challenging for them. And it sounds like they ended up doing okay. There is a maternal cousin who's 8, who mom reports may have autism spectrum disorder. As we kind of alluded to when Abby was talking, some of the things that the family spoke about in terms of diagnoses may not be correct, or may not, from our point of view, they may not be, the medical diagnosis. So it's kind of hard to tell if this child was actually diagnosed, and she wasn't sure of their exact behaviors. And then her mom does have a history of cancer in her 50s, so that is a bit young, but not much detail there. The thing mom was most concerned about is that her mother, so our patient's maternal grandmother, has about 18 siblings. She's not sure who's full and who's half necessarily, but she believes that some of them have autism along with some of their children. So again, not exactly sure about the status of those from a diagnostic standpoint. And then just briefly on the paternal side, there was a little bit less going on, or less being reported. Dad, we talked about possible bipolar, ADHD, ASD. Again, not entirely sure. For example, when mom described that her partner might have autism spectrum disorder, she said, because he's really smart. And so we know that's not the only thing, and that's not enough to necessarily diagnose somebody. So if that's kind of what she's going off of, are 1 or 2 behaviors here and there, it's kind of hard to trust what the other diagnoses look like in her mind. There is a paternal half-brother, so this 10-year-old here, he is reported to have a lot of similar behavior. So violent outbursts, a lot of behavioral issues. He's actually been kicked out of, I believe she said, 3 Head Start programs due to violence and difficult behaviors. But with all of that being said, this is a really large family. So when we actually try to kind of look at, you know, some things specifically to see if we're worried about anything genetic at this point. Of course, that family history of autism spectrum disorder does come up. It is on both sides of the family. We have those unclear diagnostic statuses. A lot of them are distant relatives to our patient. So when we get talking about maternal grandmothers, 18 siblings, and all of those children, that is pretty distant from our patient. And there was no clear like inheritance pattern, so I'm not thinking of any necessarily single gene genetic conditions. Same thing with the learning challenges, a little bit unclear. When you're seeing a family of this size, I don't think it's uncommon to come across some people that might have an autism spectrum diagnosis or some learning challenges in school. It doesn't necessarily mean that there's a monogenic or one gene explanation. So with that in mind, we did discuss the multifactorial inheritance with that, which I shared with you guys with our last patient in the fall. But just that, yes, there might be a higher chance for our patient, given his family history, for some of these things. So learning challenges, autism spectrum, ADHD, any psychiatric conditions. But a lot of these things don't necessarily have genetic testing that we think would be useful at this time. So unless he ends up having a diagnosis of autism spectrum disorder or global developmental delay, I don't think that we need to do genetic testing at this time. If we were to do anything, it would be a microarray, which is pretty standard. But I just kind of told them that, you know, should anything change after meeting with all of our different specialists, we can certainly reevaluate. And actually, just after listening to Abby, I think definitely will be interested in PT and OT. If there's any like hypotonia, muscle weakness, you know, we can certainly reevaluate the microarray. But that's all I have. So does anyone have any questions?
Great job, Courtney.
Thanks.
If there aren't any questions, do we want to just move on to the next? Last call. Anyone have a question? Okay, Sam, are you ready to go?
Yes, all set.
Okay, and we can see and hear you.
Awesome. All right. So I'm Sam. I did the audiology evaluation for Jonathan. And so I just want to start out and I want to say that I think that I saw a very different kiddo than Abby may have because he arrived with his mom. He was seen right after pediatrics and genetic counseling. His mom did report that she wasn't sure how our appointment would go because the peds appointment reportedly did not go well. And his mother was surprised by the positive interactions that he had with us. He was smiling and appeared really excited and willing to engage with the providers from the minute I walked out to the waiting room with him. He really matched the energy of both Dr. Eichert and I and really benefited from us like being really excited and kind of cheering him on. So mom reports that he does best when he's got personal cheerleaders. He did not like being examined and he got kind of bored of the tasks at hand, but he was super engaging and had no problem with me looking in his ears. As soon as I explained how the equipment worked, he was all sorts of ready to be evaluated. And he just wanted to know how things worked. In order to get him to kind of be a part of his own evaluation, we changed names of things, like calling his headphones gaming headphones. We played racing games, things like that, to keep him engaged, just because mom did report that the previous appointment didn't go well. So maybe upping our energy would really help, and it seemed to. I also noticed that he became distressed quickly when he wasn't given the attention he was looking for. So while our like high energy really did benefit him, if we got into a more serious talk with mom, like giving her the results, he would hit and pull on his mom when she didn't immediately look in his direction. And he wanted us to focus on what he was doing and accomplishing. So he didn't do well when the attention was pulled from watching him. But overall, he was really pleasant. He was really happy, and he had tons of energy, just kind of bouncing off the walls the entire appointment, wanting to play, wanting more toys, wanting to show us what he was doing. Very interactive. Primary concern, just as Abby went over earlier, is the hyperactivity, some speech and learning difficulty. So he's in Head Start program in Kentucky, like we already know, and his mom's really concerned for his articulation and speech intelligibility. She said that she can understand him most of the time, but sometimes his like grandparents and people in the community have more trouble understanding him. And then the aggressive behavior. So hearing health history, he passed his newborn hearing screening, and mom had no overt concerns for any hearing loss, said that he hears pretty well when he wants to. Significant history of ear infections, and he had 2 sets of PE tubes, just like Abby said, in 2018 and 19, and then also had tonsils and adenoids removed. His most recent ear infection was in September of 2021, but by the time we had seen him, everything had pretty much cleared up. So on assessment today, his right ear PE tube was not in the tympanic membrane, it was in his ear canal with some occluding cerumen. So just kind of by moving the ear a little bit, I can see past the earwax and saw that his eardrum was intact. That PE tube was just kind of laying in the canal, making its way out. In the left side, he had a normal tympanic membrane. Everything looked nice and healthy there. Tympanometry, or our measure of how the eardrum is moving, showed hypercompliance, so that the eardrum was moving a little bit more, was a little bit more flexible, which we tend to see with kiddos who have had previous PE tubes or any perforations in their tympanic membrane. Just the way that heals makes it a little bit more flexible. And then the left side, it was nice and normal with normal compliance. So on our hearing assessment today, here's our audiogram. Across the top, just to review, is our low pitches all the way to the left, our very high pitches all the way to the right, and then volume, starting from very low volume at the -10 at the top of the graph. 120 decibels is very loud. Anything at or below 15 decibels is considered normal. So at that green line or below it, or above it in this picture, is normal. So red and right, red is the right ear and blue is the left ear. And both ears are hearing about the same across the pitch range and all within normal limits. Oh, I ended my screen share. There we go. So all within normal limits, normal hearing bilaterally. Then just to make sure that we give him a full examination, because he really was so tolerant with us and willing to engage, we tested his ability to identify speech at a just softer than a conversational level. And he got 100% of the words right when he was given pictures to choose from. So he was given a book with instructions to look at all 6 pictures. And I would say, point to the dog, and he would just have to point to the picture that I told him to point to, and 100% correct on both sides. And then just to assess his sensitivity to loud sounds, we did a loudness discomfort level where he was wearing the headphones, and I was just talking to him about his siblings, games he liked to play, and I was slowly increasing the volume. On his right side, he did notice, he said, "That's loud," but he wasn't overtly uncomfortable with it. So there was no concern for oversensitivity to any loud sounds. So our summary and recommendations: he's got normal hearing in both ears. Hearing is adequate for continued speech and language development. And we told mom that she should return to audiologists if any new concerns for his speech or hearing and language arise. But otherwise, he should be getting hearing screenings through school and should be good to go. Now I'll stop my screen share. Does anyone have any questions?
I have a quick question. Wonderful presentation as always. This was just something that we saw today in our evaluation was, and I'm wondering if Kelly is going to mention a similar thing. We were having him watch an iPad, and at the end of the session, while we were doing the end of the examination, and he just really wanted the iPad on louder and louder and louder for volume, like loud. It was the loudest we could go, and I didn't know. I'm assuming it might be coming from more of a sensory aspect of like seeking that more input. But I didn't know if from an audiology perspective, if you see that in kids who just like want things louder and louder, and if that's something that you guys kind of deal with ever.
The loudness of our devices is something we always talk about, especially with our kiddos who are constantly wearing headphones and wanting it loud, just because we don't want them to damage their hearing. But sometimes it's easier to focus when we're turning the volume up or something like that. I wouldn't be concerned for it on a speech standpoint because he was just absolutely excellent in our evaluation and showed no concern for any hearing difficulty. But it could just be him wanting to get more of that auditory input and kind of wanting to block out maybe any excess noise that is in the background.
Thank you.
Sam, great job. I was just curious how long your appointment was.
We were in for maybe about 45 minutes, but he spent I was surprised at his behavior because he spent about 45 minutes in our waiting room too. So I was really concerned, and Mom was really concerned because we had waited a long time. We had left a car, one of his toy cars with GDBP prior, so she was really concerned about it. And it turned out really, really well. But we were only with him for about 45 minutes or so.
Okay, well, great job.
I think we do get the advantage. We have probably the briefest appointment of all of you guys. You know, when we see psychology going on for 3 hours and sometimes 4 hours, I'm like, man, you guys are rock solid. We have to zip it through and make sure we get through. So yeah, it is different when we don't have to spend 2 and 3 hours with kids.
And he did get bored of tasks. So we played like a bouncy ball game, and I did have to like kind of move the bucket around the room, start racing him. When he was kind of done, I had to like kind of find new ways to keep him engaged because you could see that if he was done, he could have melted down, kind of the way that like if he wasn't getting the attention he wanted, he was a little bit more aggressive with pulling on Mom. So it was definitely a balancing act, like Maria said in the chat. But for us, I feel like I saw a totally different kid than Abby described.
It sounds like it.
Any other questions for Sam? Okay, Maria, I think you're up next. Are you ready to go?
Yes, let me just share this.
Okay, and we can see and hear it. Or hear you.
Okay, it should be up now. Hi everyone, I am Maria Matasha and I'll be reporting on the speech and language evaluation for Jonathan. Here's a general overview of what I will be talking about today. First, we'll start with the background, then we'll go to language testing, and then third will be impressions, and last will be next steps. So starting with our background, we know that Jonathan is 4 years old with the primary language spoken at home is English. He is currently in pre-K at Gallatin Head Start, and he has an IEP and receives speech therapy for articulation and a borderline expressive language disorder, which we got from the IEP sent from MARTA. He does demonstrate phonological processes, and we can go into that later, but Mom's primary concerns were related to Jonathan's behavior. So in my session, Jonathan's overall attention was limited. He was overall inconsistently cooperative. We did utilize a visual schedule like the one over on the left. So he moved one of those number pictures into the all done bin every time he finished one of our subtests. And that kind of kept him on track, but we also used edible reinforcers and a prize as motivation. He communicated with phrases and full sentences with gestures. He demonstrated shared enjoyment. He showed He responded to social bids, so everything was good on that front. Socially, he was oriented facing me, but he did get a little silly and started speaking in a monster voice. So we gave him verbal prompts to like redirect him and show him what the task was. In regards to repetitive interests or stereotyped behaviors, he didn't demonstrate any that were concerning for something like autism spectrum disorder, but we did notice that he looked down and then he eye rolled, and then sometimes he would poke his eye. And I think that was mostly due to attention. And so generally speaking, we reported this to mom, and she said that this is how he is at Head Start and this is how he is at home too. And something to note that was different than the rest of the evals was that mom stayed outside of the testing room. And so we just took Jonathan back with us. So what we start with are 2 caregiver response forms. One is the developmental history, and the second is a child communication checklist. So here's an example of the caregiver response form for the developmental history. Something to note is that mom's primary concerns were regarding Jonathan's communication, and that he is not very good at talking or saying words right. And then another thing to note is the hearing tests, and we know that he just had one, so he passed, and those are within normal limits. And thirdly, when he interacts with peers, sometimes he just doesn't show any interest or emotions, and he sometimes gets aggressive when he doesn't get his way. This is an example from the Children's Communication Checklist, and this is looking at Jonathan's communication strengths and difficulties, and mom rates those based on frequency. So 0 being less than once a week, and then 3 being several times a week. So now going into our assessments, I first administered the SELF P3, which stands for the Clinical Evaluation of Language Fundamentals Preschool, and it's broken into these 6 subtests. And so I want to go into each of these subtests now, just so we know what demands were placed on Jonathan and what these subtests look for when we see them in a chart review, for example. So sentence comprehension is looking at how well a child understands increasing complexity of language. So I'll say, point to the picture that shows I can wear this, and I'll have to point. And as it goes on, we want to know, does he understand these different structures of sentences, such as for passive voice, the boy is being followed by the dog, or can he understand which one is not painting? For word structure, we're looking at expressively what structures of words are in his ability. So we're looking, does he have regular plural nouns such as horses, or does he use pronouns appropriately? Does he use future tense appropriately? Expressive vocabulary looks at his verbal output, what vocabulary he has. So I'll show him something like this, and I'll ask, what's this? And I have to say a bird or a sock. Oh, I think that was formatted wrong, but it's looking at different categories of vocabulary words. So does he understand musical instruments or verbs or scientific terms like a telescope or a scale? For following directions, this is looking at what he understands. And we start off by doing a task that is similar or familiar to Jonathan. So first we'll start with pointing to our head, our foot, our eye. Then we'll scaffold to something, including the term go, to kind of control that impulsivity. And I think Jonathan definitely benefited from having that go word to let him know when we wanted him to do the task. So we build on pointing to body parts, but then we include the term go. And then we move to something in a picture. So point to the monkey's nose, go. Point to the monkey's mouth, then point to his hand. So we're really including those temporal and like those spatial concepts of before and after and first and then. So at the bottom, we see, I would ask him, First, point to the dog, then point to the monkey, go. So we're looking at, can he execute that accurately? For recalling sentences, we're looking at his language abilities, what he can repeat after me, relying on his own language structures. So I'll say, the rabbit was not put in the cage by the girl. And he actually said, rabbit not put in cage by girl. So a pattern that we saw consistently throughout this subtest is that he is omitting articles. So words like the or a. So my impressions of this subtest, the scaled scores, the average scores range from 8 to 12. He scored in the average to below average scores. So in the green section, we see that sentence comprehension was average, and then the other scores in the red area were below average. Those scaled scores are then converted to the index scores, so we just add them up. And he scored mildly below average and then moderately below average for that expressive language index, which is consistent with his IEP at school, that he has a borderline below average expressive language disorder. The next test that we administered was the Goldman-Fristow test of articulation. And so we looked at his articulation of consonant sounds in words. So this is an example of what it looks like. I would show him a picture of a duck, and he said, dut. And I would ask, what sound does it make? He said, tat. I would show him a picture of glasses. He said, datis. And for frog, he said foie, and he said the color of the frog was D. So that's looking at the place of those consonants in each of those words, and then what he's replacing those sounds with. So on that test, an 86 to 114 is average. He scored 63, which is severely below the average range. And then on that caregiver response form, the CCC, she rated his communication strengths, and she indicated a score of 68, which indicates severely below the skills of his same-aged peers, which is suggestive of a specific language disorder and not necessarily something that's suggestive of autism spectrum disorder. So the next steps, I would recommend speech and language therapy and continuing that. Specifically with articulation, I think that's what's hindering his intelligibility. And then also building on that receptive and expressive language, while also targeting things like emotional regulation and attention. And then after completing this assessment, my reflection was that I would next time introduce a consistent reinforcement schedule. So I noticed that I would give him an edible reinforcement when he wasn't paying attention. So instead, I would give him a fruit snack after every answer, regardless of his behavior or the answer, and then fade that away so that he was more cooperative consistently. That's it. What questions do you guys have?
What do you do with like emotional regulation? Like, how do you incorporate that into your speech language therapy?
I think there's multiple ways to approach it, but the way that I would maybe approach it would be like identifying what's expected and unexpected behavior for the scenario. So at speech, we are expected to pay attention, sit in our seat quietly, and maybe commenting on what's not expected that he may be demonstrating.
Gotcha. Thank you.
Mm-hmm.
I really like the way that you, oh, sorry.
Go ahead, Pam.
I really like the way that you added that reflection at the end and some strategies that you might try to implement for therapy, since a lot of times, at least in my experience, well, not always, but sometimes it's a different person that ends up being the therapist. Maybe the family chooses a different location or something, then does the evaluation that, does the ongoing therapy. Is that something that you would include in a report, like some ideas, or not typically? include in the actual evaluation report.
Whoops. I don't think it would hurt to include it. I think I maybe would have made a note in like a clinical observation standpoint that he did respond to an edible reinforcement. So I feel like in the future, maybe someone would read that and then implement that themselves.
I wanted to ask Maria what your thoughts were about continuing speech therapy in just the school-based setting versus outpatient in addition.
Yeah, so I think what I would recommend is receiving outpatient, but I think a huge barrier for them is that they do live so far away from outpatient facilities. So in that regard, I don't know if it's feasible for them, plus their busy schedule. So I think it's definitely important to recommend that to the family. And then the question is whether or not they want to continue with that recommendation.
Maria, I was just curious. I know you guys separate and you take him back. Was there any difficulties taking him back or separation from mother?
Not too bad. So mom walked us back to the room. She picked up the paperwork, and then I kind of got started with him talking about his dinosaur shirt, and then he kind of forgot about mom, and then she just left the room.
Great. Thank you.
So no issues really.
Maria, I really like the way that you organize things and explain things. It was really helpful. And I just wanted to make sure I heard you right on one of those ending slides that you said some of the language things you were seeing were more related to language and not symptoms of autism. Was that right?
Correct, yeah.
Okay. I wanted to make sure I heard that right, because yeah, that was consistent with what we had seen in psych too, and had really nice like interactive and social kind of behaviors, which is why we hadn't done the ADOS. So just hearing what other people had seen, it sounds like we're similarly on the same page. And then I had a question about just his presentation seemed like he had pretty good effort throughout things, but just knowing that he like likes to be a little bit silly. Did you ever have to tease apart when he was like talking like a baby for attention versus real mispronunciations or difficulty with sounds?
I didn't observe any of like the baby talk. I think when he did start talking like a monster, we kind of stopped and we're like, okay, we need to know what you know, so let's focus. And so when we told him that, he seemed to put forth best effort after that. But yeah, like you said, no concern for autism spectrum disorder.
Because he doesn't have any social, like what is is it just because he doesn't seem like he's completely asocial, or what is it that I'm just curious?
So in a speech eval, and I'm sure my psych friends can speak on this too, but we look for a lot of things. It's not just social responsiveness. But because he was social and because he has this layer of ADHD or like attention issues, I think that was a clear rationale for why he's demonstrating some of these behaviors like eye rolling or poking his eye.
But but there's a co-occurrence between ADHD and autism. So not saying that it doesn't say that he's not that he is or isn't autistic, but there's also a lot of autistic people who can do some sociality. And so, I mean, I was pretty outgoing when I was a youngster, and one of the reasons I probably didn't get diagnosed until later. I'm not saying he definitely is autistic, but I think some of the ways that we have that, some of the criteria of what we do for that, I'm just curious what else rules that out, just because of how broad the spectrum is as well, and how many different things have sort of gone into what does or doesn't constitute. I mean, sometimes there's these very niche boxes, but then there's different groups within it that go outside those boxes as well. And I think it's some of the reasons that we've had a lot of later diagnoses, especially within the idea of functionality and how much functionality affects somebody, and that it doesn't go into the point of to completely taking away functionality. Sorry, I don't mean to be, I'm just curious. Sorry if I sound aggressive or anything.
No, I appreciate you asking the question. I think sometimes we see kids who have really good strengths that sometimes mask things that are needing more support. And so you're right that, let's say that Jonathan had really good social skills, but he might still have autism. That's something that we consider on a holistic basis and not just one aspect of communication.
Yeah, and I can just chime in briefly. I know with psych, mom didn't raise any concerns with autism. And when we went through and talked about the full range of symptoms with social skills, repetitive behaviors, routines, any stereotypy, she wasn't reporting any, and we didn't see any either. And we were able to kind of interrupt him in different ways or redirect him, and he seemed pretty comfortable with that. So just kind of the range of reports and observations across different areas seemed that it was more ADHD and not like autism for us.
Yeah, no, I'm just curious because I mean, I agree with that, but I know not everybody who's autistic also flaps their hands or does repetitive behavior in the exact same way. So it might in some ways go within the ideas that seem like what, to some extent, what anybody would be able to do to some extent, just sometimes a little bit more, but not in a point to where you would say that it was completely because there's ever, I mean, I'm not trying to, and I just mean, it's just, I'm not saying he's autistic. I'm just curious about how sometimes we classify it because there's a whole, there's different people within different ranges of things, and things can go within that sort of curve. And I just, sorry, I don't know why I'm discussing this so much. I'm just.
No, I think that's helpful. And I think that's helpful, at least for me, to be mindful of to like think about what might be a repetitive behavior or specific interest that doesn't look like some of the examples that you gave. So really trying to talk to the family or observe in certain ways so that, it might not be an obvious thing or the first thing you notice, but teasing apart if there are those behaviors, but they just might look a little bit different than what we would expect. So I think that's really helpful.
Yeah, and I just know that goes into a lot of disability things. I mean, and I know Steph and Jen know this, but somebody who I used to work with and who passed away, and I don't want to get too into the details, got late diagnosis at 34 of bipolar disorder because he wasn't considered non-functional enough, even though there were some signs of things there, such as you like to do things really like sort of a lot, and sort of, and so it's just, I know with some of the deficit, I mean, so we fit into it well enough to sort of be able to mask it without getting into some of that. And, I mean, obviously there's way more that we also have to do to support people, but some of those some of the ways that we put cultural or what's functional enough can also make it for some of those later diagnoses as well. And I'm sorry to make things complicated or get too personal, or sorry.
No, I think you bring up a really good point, Jason, about how some of the limitations are with a clinical subjective diagnosis to some extent, that it can be hard, and sometimes that following someone over time, which is something that we have a benefit of being able to do. And like developmental peds is something that I've seen over the years, is that some people get missed and then they get diagnosed later for a lot of the reasons that you just stated. So I think it's a really great question, and part of the difficulty that we deal with in this field is that it is, like you said, I mean, things can be missed, you may not see it, or it may not get reported. And so to some degree it's imperfect, and part of what we need to do, I think, is monitor individuals over time too.
I would also support that that's the point of having this training team discussion is that we have those questions that are brought about by all of us of how did you come to that conclusion? And that's our job as professionals to be able to describe that, not just to our peers, but to the families that we work with. So I think that that's the whole beautiful part of having the LEND training team discussion, is that when we have questions of how did you come to that conclusion, if we don't ask that, then that's going to be harder for trainees who are the independent professional to be able to answer those questions when they come up to those parents having those same concerns and questions. So I think it's the beautiful part of LEND.
I had one quick question. Maria, after your evaluation, what is it that you think may be the cause for his language issues? And since you're thinking it may not be, connected with autism, and because the prescription was speech therapy. So I guess what I was trying to figure out was if it is related to something that is biological in origin, how do we know that speech therapy would work? Or is it that you were thinking that the root cause of it is something, and that's what prompted you thinking it could be corrected? So what are your thoughts on why he's rating below average in these areas?
Yeah, thanks, Pat. I appreciate your question, because I know we had talked about in previous LEND sessions that you can't fix a medical problem with a behavioral change, or for example. But I think in this instance with Jonathan is that because of his attention issues, I think that is negatively impacting his ability to understand or learn language. And so we know that attention is kind of the foundation for everything. If they can't attend, they can't learn or pick up on these things that we are teaching through conversation or through incidental teaching or something like that. So I think that is the basis for it. And I'm not saying that speech language therapy is like gonna fix all of his problems. I'm just saying that, like, based on what we gathered from the assessment, this is what we would address in speech therapy. Does that answer your question? Okay.
Okay, if there aren't any other questions for Maria, we can go on to the next one. I think Donna, you're up.
Yes, I am. Thank you.
Mm-hmm.
I'm going to find my share screen. Hold on. You guys see my screen? Nope. We see it.
Yeah, sorry, I couldn't get off
Okay.
mute quick enough. We can
No,
see
you're
it.
fine. Okay, so with little Jonathan, we did see him last week. I'm Donna, by the way, ITT Team 1. We met with him with Mom last Tuesday, the 15th. Mom does work outside the home. Dad does not work. Dad does receive Social Security. He does attend the Head Start program in Gallatin County. Again, some of this is going to be repetitive, what we've already heard. And he does like to ride his scooter around the house. With that being said, we did a semi-interview with Mom. We did do it during the occupational therapy. We watched through the observation window with Mom. Molly Sawyer was there with me, and I did lead the interview. During the OT eval, he did start acting out. Mom was concerned about that as we watched through the window. We did reinforce with her that this is kind of what we do want to see so we can get a proper diagnosis on him. She did state a couple different times that she has ADHD, and she kept blaming herself, or is there something else that I could have done to assist with him not acting out? We asked what his strengths are. She said he's a very loving child, but for his age, she does feel he's a very strong child, and he's only going to get bigger and stronger. And he does also play well with his cousins, that the family does get together quite often, and he plays well with them. She doesn't see a lot of outbursts when he's with his cousins. So for her concerns, as was said before, she brought him into Children's due to his behaviors. She's questioning whether or not he is ADD or ADHD. due to the fact he does have younger siblings and he does do rough play with them. With that being said, I believe he has a 7-month-old sister, and that when he wants to carry her around, he hugs her extremely tightly. So she's afraid of him squeezing her a little too hard. He likes to run away when in public places, stores, restaurants, and he cannot sit still in school. So with that being said, when she does pick him up from school, one of her concerns is what she gets from Head Start is everything he's done bad that day. So when she hears that every day, she gets kind of down on herself, blames herself again for what did I do wrong. At this point, during some of these questions we were asking about her concern, she did say that she and Dad both have been through parenting classes. I know before I think we just heard that Dad did. She said she and Dad have both been through parenting classes. Another concern that she did give us, which I don't believe was brought up, is she did state to us one of her concerns was when she first learned that she was pregnant with Jonathan, is that Dad was actively on drugs at the time that she conceived him. Dad told her that since he was not the one carrying the child, that the drugs would not affect him. It was only if she was on drugs at the time. I kind of took it upon myself to kind of Google that. I really can't find any information pertaining to if it would or not. And then she also stipulated with the melatonin, she would only give it to him when he had bad days. So I don't know if she's consistent with giving it to him every night. So right now, her main priority is to relieve stress at home and at school, just for the fact that when she's home, she's doing a lot. She gets home from work. When she picks him up from school, she hears everything he does bad. She would like the results verbally and the documents also for reference and to take notes. Again, when asked this question, she did say, with my ADHD, I might look like I understand what you're telling me when really I don't. I did let her know, please, as a parent, to ask questions. For strategies for home and school, whatever strategy you come up with, she wants basically the plan to be put in step 1. And how do I start step 1? To move to step 2, how do I start step 2? So she wants everything, if she can, broken down for each thing that we recommend for her to do or try at home. And that was about it. Any questions?
Donna, did she say anything about her relationship with Dad? Like how they support one another?
She did not.
Okay.
Like some of the specific questions we asked, she kind of started to ask the question, then just went on to something else and kind of came back. That's how she kind of gave us off the cuff about Dad being on drugs when she conceived him.
Yeah, I actually had that issue with her too. I had to really nail down and ask very direct, specific questions to get
right. And she kept looking through the window to see how he was doing.
Yeah.
So she was kind of glad she was able to see what he was doing, but then would go off in a roundabout way about the question.
Yeah. Okay.
I think something important to note, Mom was really open to discussing, she shared with us discussing medication options. She's really open to trying different behavioral strategies. One she did mention to me though was, that I told Jonathan if he was good all week long at school, then he would get a treat at the end of the week. And so when we think about age appropriateness, possible diagnosis, how to help Mom understand maybe breaking down behavioral goals into something really small. She's seeing some success in like really this immediate reward that he's getting maybe during some of our appointments. So hopefully that she's seeing that and she sees it's possible that an immediate reward could help. But again, when she shared that for me was some insight into, she knows that there are strategies and things she can do as a parent to encourage some more positive behaviors at home. But that idea of extending it to an entire week at school, maybe not age appropriate for him at this time.
when Shannon and talked to her about her and dad's relationship, mom mainly steered the conversation to dad is home, but mom does all of the caregiving for all of the kids, unless she's not physically there. The school also shared that her mom used to be a big support, but her mom is not okay that she is back with dad, does not support their relationship, and has backed off on her level of support.
She kind of alluded to that also, and she also stipulated that her parents don't know how to handle him. So I don't know if once we get any sort of behavioral, any sort of strategy, so she can also help mom and dad with those strategies when he's maybe over there. But yeah, it doesn't look like she has a lot of support at all, since she needs some me time just as a parent. I just don't know how she's going to get it right now.
Yeah, I would also think that, being able to break down the strategies for her and then having some of the support, especially because a lot of times adults with ADHD don't have support. And if he's also, and then sometimes if you're sure, if it's hard for you to do something, then to help somebody else do it, especially if you don't exactly understand it or try to, then we create sort of this complexity of how do if I have enough trouble paying attention or breaking things down, and it's hard to help somebody else if I don't know the strategies myself, or it's sort of, you hit that wall of, oh, well, you had it in school, but then with stuff with like learning disabilities and ADHD, it drops off after you sort of get done with school. And so some of those strategies don't apply, and making sure that it's something that can also be designed to be helpful for her, and then making sure that it translates over to how she feels like she can help him. Just because I know with somebody with ADHD myself, it's sometimes hard to help somebody else organize if I'm having enough trouble organizing things myself.
Yeah, it might be a useful thing for her for organization also, to show her a time schedule, like when she gets home from work with the kids at this time, with a timer for the next 15 minutes, I'm cooking dinner for I don't know, but she wants it broken down step by step by step, and how she can do this.
I did think too, Donna, do you remember? I felt mom was really insightful when I asked her, is this a more recent struggle? I'm just curious. And she looked at me and she said, I've always struggled, even since he was a baby. He's been a handful for me. And I felt like that was really, that was like a moment where it was just complete silence. And then she just looked at me and she said, I've always struggled with him. Even as a baby, he just wasn't happy. And I felt like, again, as a parent, that was really insightful of her to just kind of take that moment and kind of reflect back on it. She's just always really struggled with her kiddo.
Right. And that he never slept. Even when he was an infant, he never really slept.
And that's one of the reasons why I'm interested in also and I know I sound like this is a weird sort of thing, but like with the gastrointestinal issues, with some of the sleeping issues, those are also, have a occurrence with being with having autism. So even though there's some ways that it doesn't seem like what it would be like with the more pronounced version, there's also some subtleties there that sometimes get talked about. So I'm not saying that it is, but I'm also not seeing things that say that just because he isn't showing some of the more classical symptoms, that there's not other things that might, especially from a biological perspective, that sometimes also affect other autistic people. Sorry, I don't mean to keep harping my...
Abby, I had a question about, sort of related to what Jason's talking about. At what point would a sleep study be indicated for a kiddo like this who's had a long history of not sleeping well?
Usually snoring, gasping are big things. He did have his tonsils and adenoids out. That's usually kind of the first step. And mom wasn't endorsing snoring or gasping, so that is one thing to think about. You always have to consider in high BMI too, because there's obstructive sleep apnea, which I think he's pretty proportional. So I'm not as actually concerned about And I think BMI, I hate BMI in pediatrics. BMI is just really a conflicting thing in adults, but especially in pediatrics. We do report it though. But yeah, so I think snoring, gasping, restless sleep, you always wonder about it. So I didn't put this in my overall review because I want to be really direct with this mom and give her only things that are like pertinent. But I think with restless sleep, you always worry about like iron deficiency and other causes of restless sleep. So zinc deficiency is another one, and then lead. So we always check those sometimes with restless sleep, mostly with iron deficiency. And that's a blood draw. So that is something to think about rather than going to a sleep or like sleep disordered, which mom was not really endorsing, like sleepwalking, sleep behaviors, parasomnias. So based on the history, the one thing I would look into is maybe iron, just to make sure the restless sleep is not due to something else.
Do we know what he eats, like what type of things he likes or doesn't like to eat, and what is sort of this, because if you're going into some of the things, and sometimes so for some people who are sensory eaters, or things that they do or don't like, and that that might give some insight to is it, it doesn't necessarily, because it would go into the idea of the deficiencies of some of the stuff, but it also might, if there's like asking like why, like, or asking, do you know why he might like this food or not? Because sometimes there's textural reasons or other things that might also go into what somebody eats, which then could go into some of that stuff. Sorry, not to make things complicated.
No, and a diet history is like really important if you're going to go down the iron deficiency route in the future. Like, I do think that's something that I was thinking about if I follow with him, looking more into the restless sleep and seeing. I think you just try and target the biggest bang for your buck right now. And I don't believe yet that he would meet criteria yet for a sleep study, but I do think you have to consider that always. And we like to keep our differential broad. So, but I didn't believe that he had enough to go off for a sleep study, but maybe behavioral sleep, but he's kind of out of our resource area too. Marta's shaking her head. I know this is like a nightmare, I'm sure, for trying to find resources for him. But yeah, I think it's a good question and something to consider.
Thank
you. I will be sharing food very shortly.
I have a quick question. In evaluating these children, sometimes what we see is impacting children is sometimes influenced by the environment around them. And for instance, if a child is presenting consistently with bronchitis or asthma, but all the adults in the home smoke, okay? So we can do everything with handheld nebulizers, everything to treat the bronchitis or the asthma, but because of the environmental influencers, sometimes it cannot get under control. And so what happens in scenarios like this, when you're trying to focus on improving outcomes for the child, but the mom and dad, who both seem to have their own set of issues, theirs are not getting resolved. And so we're focusing on the child, but there's some outside influencers that will potentially impact the outcome of the child. So in the end, do we look at just the child, or do we look at the potential, the dynamics for the whole family, and how it can potentially impact the child and the results we're trying to get?
And I had messaged Marta earlier saying, like, I do think I need to be very clear in the ISS with psychology, in the ISS about like how important consistency across caretakers, like, I do think that's a big component where we need to have buy-in. And we can't provide family-centered care with only one part of the family. And I do think sometimes you get to a point as a provider where you say that outright, like where you're very upfront about that. And you're honest about that, because they can see our nose. If they can see our nose, they can see everything we have. And I think mom really, really wants a solution, but I do think we're at a point where we need to be very open and honest about being like consistency, the environment. We need buy-in from everyone in the family. And that's going to be a conversation, I think, that will be tough, but we will have to have at the ISS. Yeah,
Do
I
we
know.
know-
I agree, Maria. Dad needs to come to the ISS.
Yeah.
I would love for that.
Can the
We-
grandparents be in the ISS or on a Zoom call with ISS if she can get the grandparents to do that too? Or is that something she would have to make that decision?
Mom has to make that decision. Mom and grandma both work the same shift at the same place. And I already know mom is taken off these days from work to be at these appointments. So I don't know that grandma would be able to come. Shannon has laid the groundwork and has started saying it would be great for dad to be at the ISS. So we will continue to lay the groundwork that we would love for dad to be here however he can be. If that's him on Zoom on his cell phone at home, great. We'd love for him to be physically here, but however we could get dad, we would take him. School has the same comment that they wish dad would buy in. They wish they could get engaged dad. They've been trying to engage dad since this kid was a baby, and they haven't yet engaged dad. They're also, just to throw another layer in here, I'm pretty sure this kid has a decent trauma history. It is substantiated domestic violence in the home that resulted in both parents being required to take parenting classes, which could mean that mom also had charges of dependency, so failure to protect from an abuser. So these kids likely have witnessed, him and his older sibling, hopefully not the baby, have witnessed some domestic violence among their parents. And hopefully that arguing and those disagreements are better now than they were in the past. But we don't know what arguments look like between mom and dad or disagreements look like between mom and dad in the home currently either. To date, she hasn't said anything concerning that if she disagrees with dad or if she takes these reports home to dad, will he agree? Even say, yes, I believe them, which isn't going to be an issue in accessing services when he's the person who's home with them to get them to the services. So Pat, he lives in a system and we have to treat the system. We can't treat him by himself. Is how I talk to families about it.
Yeah, I think I was thinking more along the line of the fact that it sounds like mom and dad have their own set of individual issues. And how do we treat the family? Because by treating the family, we ultimately treat one of the members of the family. Otherwise, the cycle just keeps happening. Mom has, let's see, is it mom has ADHD or what does she have?
She reports she has ADHD.
Yeah, she's got ADHD. And we don't know whether or not she's been treated or seen any. And so it looks like this is going to be a vicious cycle. The handheld nebulizer, they keep smoking. Handheld, so you know, it's just a vicious cycle. So that's why I was wondering, do we have anything in place where we're looking at the family as a unit and what their individual needs are, so that we can improve the outcome of the one who originally came to us for evaluation?
I think it's a little bit tricky and a very important point, but I think first step is kind of building rapport with the family in general, and that is probably by trying to help them with some of these steps with their son. And then, as you know, we can, I think, approach some of it at the ISS, but then hopefully if this is somebody, I mean, and ideally that we're following over time, that as you build that rapport with the family, you can start to, you know, feel more comfortable about trying to make some recommendations that may go a little bit beyond what their referring question was and what their questions are. I think it is a little bit tricky because, you know, sometimes it can be a bit off-putting to go straight to those recommendations, but I think it is so pertinent in this case, as you say, with this behavior and the history. And I think it's something that we are going to have to address, but then I just think longer strategy will be, as we build rapport over time, hopefully with this family, that perhaps, you know, us or if he gets into therapy, they could do the same thing, is that you're encouraging family members to get, you know, other issues treated as well that are related.
Thank you.
Okay, and I know this is all very important, but I think we need to move on to Kelly to make sure we have enough time to hear her presentation. So she is the last one that goes today. So Kelly, it's all yours.
Ooh, last one. All right, let me share. All right. I'm having a brain fart. All right, can we see the presentation?
Yes, we can.
Great. So I just kind of want to paint a picture. I feel like Kim and I saw a very different child, and maybe something that was closer to what Abby saw when I went to go get him from the lobby. He was hugging mom, walking really slowly back to the room. It's a decent walk, and he was very hesitant to engage with us. When we tried to sit down and offer toys, food, any excitement, he refused and just wanted to hold mom. And mom encouraged to step out of the room and kind of let him have his space. She said this was typical of when he is going to school. She just kind of pushed him off. It took about 2 people to separate, and she was talking to Donna and watching in the observation deck. And Jonathan was like laying down on his stomach with his head like this and not looking at us. I want to say it took probably like 5-10 minutes for him to kind of slowly warm up. Kim, Jamie, and I were tossing a ball. We were playing. We were making it as fun as possible to kind of motivate him to want to engage with us. And through time, he did eventually come and interact with us, and we were able to see some great things. So I was unable to complete a standardized assessment during this evaluation just due to behavior. So I created an occupational profile, so asking mom a lot of subjective information. And then I did a lot of clinical observation. So that was play-based. We had swings, we had bubbles, we had a snack, and we did some coloring. And then I had mom fill out 2 questionnaires, the sensory processing measure, preschool edition, and the ages and stages questionnaire, which I will go into more detail. So as we know, and I feel like I am a broken record right now, his behavior was a very big concern for mom, noting the limited strategies to calm besides deep pressure, the lengths of the tantrum and frequency, and the concern for safety of siblings, as well as sensory processing difficulty. So he is constantly moving. He was jumping, crashing, doing like little flips and somersaults, which stressed me out in the evaluation. And he really seemed to seek out heavy work. So pulling things, pushing. And then the other thing we really noticed was him grading his force. He really gripped the crayon pretty hard. And mom said that was typical. And observation wise, like if you were to tap someone's shoulder, it may look like he's pushing just because he's unaware of his body awareness and how much force he is using. So when I asked mom what a typical day looks like, and I think we all kind of are getting the same thing, days are really inconsistent for him. Mother reported picking him up and dropping him off to school, but I feel like we've heard different things about dad. So I don't know if something had changed. And then Donna had mentioned, so when she picks him up from school, they come home, they try to get his homework done. He is 4, so I'm not quite sure what the homework is. And looking back and reflecting, I wish I would have probed and kind of asked her what that homework looked like. And that is something I would encourage the treating therapist to ask about. But she reported it's a constant battle and it typically is difficult to complete or get done. And she said cooking dinner at home is really hard with managing his behaviors and the concerns for the other siblings. So going into the activities of daily living. And Jason, I hope this kind of answers your question a little bit more. He is a picky eater and really dislikes the slimy and wet food. And also grazing and mealtime is very unstructured. He does not sit down. He kind of will take a bite and then go run around and do something and come back. And also mom, from a sensory standpoint, really reported he enjoys crunchy food, which we did see he was eating chips and he enjoyed the crunch. He made a bit of a mess and enjoyed also stomping on the chips as well. For bathing, she reported it is difficult to start bath time to get him into the tub, and he really doesn't like water going over his eyes. She reported that she did get goggles to kind of help with that, but bath time is a bit of a struggle. And also I kind of probed when I asked about if he enjoyed swimming. She reported that he's a type of kid that would rather be outside the pool running around rather than swimming inside the pool. So I thought that was interesting. For dressing, I asked, and she said he is capable of dressing zippers and buttons, but wants mom to do it, which is consistent with what Abby had said. And she also noted that when wearing a jacket, his specific jacket he had, it must be zipped and hood up at all times. Going further, we talked about grooming and hygiene. So Mom reported he really dislikes his hair being cut, nails being trimmed, but it has gotten better with age. And I was really shocked when Samantha was saying how well the audiology went, because Mom said his ears were the most sensitive when getting haircuts, and it's really difficult right in that area. So I don't know what magic Sam worked, but hats off to her. And then she reports no concerns with toothbrushing until recently. He did just fine, he did it, and now he refuses and doesn't want to do it. And I don't know how often his teeth are getting brushed. Toileting, I kind of probed based off what Shannon had said about the urination in public spaces. Mom had no concerns, and she said he was toilet trained at 2 and left it at that. For rest and sleep, I feel like we've kind of hit this pretty hard. Mom noted difficulty falling and staying asleep. He's really restless, and that he typically needs to sleep next to her. And she reported that I believe it is in the parents' bed, and they are trying to transition to his bed. And I kind of tried to ask about the bedroom situation, but I didn't get an answer, and I felt like she kind of dodged it. So that would be something to maybe look into further. For education, we know that he is at early Head Start, receiving speech therapy, concerns for the fine motor delay, behavior concerns with the drop-off. It can be pretty difficult for him to separate from Mom. And again, the inconsistent schedule and attendance. I don't know who's taking or dropping and picking him up, and I don't know how many days they're going. She said 3 to 4, but we've heard different things. So again, I'm not too clear. And then for play and leisure, she reported playing rough with others, and I think that can go back to him grading his force. He doesn't know how rough and how big he is compared to the other kids, and he has difficulty sharing. And we heard, again, social participation, difficulty playing properly, sharing toys, and playing appropriately. And I also know he has difficulty running errands with families for elopement concerns as well. And then for instrumental ADLs, and I think that's more of like, you think about chores or home management. So he typically will refuse to clean up his toys. Again, difficult to run errands with for safety. But Mom reported he really enjoys Kings Island, has no fear, will ride all the rides, but did note he will use a wheelchair when his right foot starts to hurt. So I know Kim followed up with that today. So for energy and motivation and drive, he was very impulsive and very motivated to do what he wanted to do. When we put any demands on it, it kind of had to become a game, and it had to be his control, which we had to be careful about, because I feel like we got stuck in some situations and had to slowly pull away from what he wanted and what we wanted. And again, for emotional, he just seemed to really have difficulty recovering from hurt or disappointment, displaying appropriate emotions for the situation that was occurring, difficulty coping with stressful events or even minor events, and did not want any support. He told us to leave him alone a lot and didn't want hands on him unless, again, he had control of the situation. I don't know. Sorry, I just saw the chat. I want to make sure. So moving into sensory, because I feel like this is a big part of him, and I feel like I've harped on this a little bit, so I'm gonna speed through it because I know time-wise too. So you can be over, under responsive, you could be seeking, you could be craving. So kind of, I feel like we all have sensory needs that need to be met, and we kind of learn to cope with them as we get older. And it really appeared that Jonathan was a seeker and a craver, but also had some over responsive as well. So I completed the sensory processing measure right here. And I like to kind of show the dots. So this white box right here is showing the typical range, which is where hearing fell, which I guess correlates with what Samantha saw. And then up here is where you see definite dysfunction. So he scored fairly high in the social participation, vision, touch, body awareness, balance and motion, planning and ideas, and just his overall sensory system. And again, he appeared to be very over responsive and seeking and craving. And I'm not going to go into too much detail about this, but if you guys have any questions, you can feel free to reach out. It was just noticing for visual processing, his over-responsive. He had difficulty paying attention when there were a lot of things going on. Well, mom reported that. And also the seeking and craving. He always enjoyed watching things spin and more than his peers would. And then for the tactile processing, so that touch, he always pulls away from being touched lightly. He prefers to touch rather than be touched, which I do think we saw in a lot of the evaluations. And again, he's gagging or vomiting at foods that maybe that he dislikes having in his mouth, like the slimy foods, as well as he does not like things being like his face washed, which mom reported as well. And then seeking and craving, he also reported sensations that should be painful. And mom noted that he would touch the stove numerous times and not react or didn't think it hurt. So just some safety awareness concerns as well. Auditory, no problems. So vestibular, and that's just kind of the movement. So he's always moving. I don't think he sat down once in the OT evaluation. He's spinning, crashing, and typically moving more than the average kid. And then I think another big one is the proprioceptive input. So that is just that joint muscle connection. And he just doesn't have any awareness of how hard he might be grasping a pencil or a crayon or touching someone else or throwing a ball. We noticed that he had a ball and instead of tossing it to me, it was more of a chuck, which was my fault. I shouldn't have put my hands out to catch it. But he just bumps and crashes and just really isn't aware of his body. And then also he was seeking and craving, and I saw that a lot in the PT evaluation. He moved like 3 mats, 3 big cloud pillows, and attempted to move a slide and was not tired and moved it all the way back across the room. And he was, and you could see he started to like calm and regulate and slow his body down and had a smile on his face. So I do think if we can give him some of that input, it would really help him self-regulate. And then again, for the oral taste and processing, he gags at the food and had no concerns with smell or olfactory. Sorry, I'm trying to run through this ages and stages questionnaire. I don't think I'm going to focus on too much because it is a parent questionnaire. And mom did ask me my opinion of some of the questions. So I don't know how accurate this is because the only concern that popped up was his problem solving score of a 20 out of 60. And she marked like for fine motor that he could draw a line and a circle and a square. And I will show you pictures that kind of say otherwise. So mom did her best on this, but I'm not going to focus on it because of time and everything else. So what's more important are the clinical observations. As I've stated throughout, we asked him to build blocks, and he was able to stack a tower of 8 blocks or so, but was unable to kind of mimic the train or the cube bridge or the block wall. And when we asked him to do these things, he wanted to go hide and then show us. He didn't want us to watch or see. And I thought that was interesting, again, going back to control, but also maybe he was embarrassed because he wasn't able to do it. He really enjoyed the swing in the OT eval, but in the PT eval, it became, again, about control. He wanted to do it by himself, but we wanted to hold on for safety concerns. And it triggered a meltdown where he was kicking, and we actually had to take 2 people and remove him from the swing because we were concerned for safety. And then these are called yucky balls on the right, I believe. And they provide some tactile input, but they're also very weighted. So he enjoyed playing with those throughout the session. And then here is his beautiful artwork that he drew in my session. The black marker is mine. So I was trying to have him imitate these lines in the circle, and the green markers are his, except this little circle at the bottom, that is also mine. So that is why I don't know how accurate the ages and stages questionnaire is and why I'm leaving it as just a self-report. And his grasp that he reported with Abby was, I would not say age appropriate. It was fisted and down, which is immature for his age. And we did recommend OT, and we actually encouraged, Mom was asking about location wise. She said Kentucky would work for her. They have a long wait list. So we just went in and put the recommendation and encouraged her to at least just put her name on the wait list. So we did recommend once a week for 12 to 16 visits. We do think he might need more based off what the treating therapist thinks, in a private treatment room. And interventions and treatments would focus on giving him that seeking and craving proprioceptive input, doing that heavy work in small doses, educating the family on giving him a sensory diet at home and possibly at school, working on some of his fine motor skills, possibly tackling some of his feeding and picky eating, and just giving the family some structure around sleep and mealtime routines. Sorry, I felt like that was a lot of information, but I hope it all made sense.
You made it. Kelly, Jason did have a question earlier. You said that he like didn't have appropriate emotions to certain things, and he just said like what were his emotions that they weren't appropriate?
Yeah. So, and anyone can correct me if I'm wrong, but so when Mom was stepping out of the room, he did not want to leave her side at all. And then I would say, I felt like it took him a long time to come around to playing with us or engaging, or even just like sitting up. Like he had his head down on the floor, did not want to engage with us for probably 10-ish minutes. Kim or Jamie, I don't know if you
How
think
much
it
of
was
that
more long.
also goes with some of his traumatic experiences, and that it is in some ways based on his experiences appropriate because of some of the things that he's been through, or that it is, I mean, I know for myself, and some of this is because there was a lot that I saw in myself with different things, not that I always see, I mean, you always see sometimes other things with different people in commonalities, but one, I had a lot of trust issues of other people because I used to be more extroverted, then I became more introverted as I got made fun of and shy, and took up other strategies of how to react to that. And then even with like sensory eating, when there's stuff like, I don't, like, how do you figure out like some of that stuff? I know with some of the coordination stuff, there's like even different things of like how much of it is that we're fixing or trying to understand how it works with him, and then seeing what sort of also overcomes based on environmental, based on sensory, because it does seem like he has a number of sensory issues. So picky eating can be a part of sensory eating. So I mean, like how much of it is also working within some, like even some of the stuff about physical coordination, there might be things within the brain body connection. And sorry, I know I'm like saying a ton of different things at once.
No, I always really appreciate your perspective. And I think the one thing and that's why I feel like I kept asking everyone was like, how long did you spend with him? Or like with Maria, you were able to separate with no concerns. Kim, I also saw today, we were able to separate with no concerns, but you could see with Abby, there was a little hesitation and separation. So I feel like in my head, I'm trying to like understand what is causing the separation in certain situations and what was different with each evaluation. Because like for me, Kim and I spent about 2 hours, and you could kind of see his behavior tip, I would say within the 45-60 minute mark, and he would kind of get tired. And I do think that's appropriate. He's tired. We've asked him to do a lot of things, but like in the beginning, trying to understand what is causing that behavior. Or when he was on the swing today, he tried to like kick and hit and became really upset. But on last week, the swing was totally fine. And Jamie was able to hold it and take those breaks. So for me, I think I don't understand what is causing some of the behaviors. And I think it's important for us to like really step back and see what's the underlying issues. In my head, I do kind of think there is a lot of trauma and we don't know the whole story. And that could be a big part of it too.
Could some of it also be the amount? I mean, I know it goes and it can go in ebbs and flows based on some things with energy of like being overwhelmed or feeling like in just different situations, because, I know that that for some people, you know, if you're doing, I mean, I know that was a big day today, and I know there was times where he did, but what happened in between, or, you know, if there was a lot of external stimuli, or sort of, you know, there was something that happened in between, or, you know, I mean, I know it makes it tough to track because there can be a lot of reasons that can internally or externally make, you know, different behaviors or different reactions to different things. Sorry, I don't
No,
mean to be a hard
absolutely.
there, and I don't know, I'm sorry.
Jason,
No.
you're bringing up some really great points, Jason. I think the main issue is that he's a complex child. We're still teasing out our kind of baseline assessment. But the thing that clinicians do ongoing, or a good clinician does ongoing, is it's not just an assessment and treatment, but every time you see that child, you're checking in again with the patient and family about things that have worked and not worked, and you're continually updating and using that information to make a better plan together. And the other thing is, this is all happening in a team environment. So we've got the benefit of having all these other folks, including, you know, the family advocates and the self-advocates, helping us to remember different parts of this. And when you're out as a clinician treating on your own and don't have the benefit of sitting down at a team, you are reaching out to colleagues and saying, hey, I'm seeing this and it's not adding up, you know, based on my knowledge or based on what we've tried. Should I be trying something else? What are you trying? How can we work in concert with each other? And so there's an ongoing puzzle to figure out here in conjunction with the family. And the questions you're asking are all appropriate. And we will keep teasing this out with, you know, some of that input and sort of, you know, assessments with the family. In the interest of time, and I just want to say kudos to all of you. I don't know that we've ever done 7 in one time. And Julie, I feel like, gets the award for being a phenomenal MC and having these gorgeous segues into things. Really beautifully done. I really appreciate the conversation, discussion, questions. And I think we'll have more of that too in the case conference at our next session. Do you guys feel like that's a good place to leave things today, and we can work on going into breakout rooms? I see some head nods. Yeah.
And I was going to say, if you had a question for Kelly that didn't get answered, if you want to put it in the chat box, I can write it down and keep them, and we can start next time with those.
That is a lovely idea. So is Jen Smith is right there.